Dr. Teja about endophthalmitis. So what he is going to tell is, which is very important from the title itself, earlier the better. Teja, again the request is stress on practical points.
Sir, actually, the outside I would like to, because our surgical recording system was under maintenance at the time, so I managed with the pictures. So
then show pictures.
Yeah.
Don't tell us theory.
Fine. So
the reason is in conferences I love to discuss situations, cases rather than then you tell principles endophthalmitis, ये सारा how to prepare amica sin वो नहीं चाहिए.
So now hi, good evening everyone.
So you are from Hyderabad. So what is this center known as?
Sir, actually I was at Shankar Foundation, Vizag, sir, under Dr. Chella, sir. So
Chella?
Yeah. Yes, sir. And recently I shifted out.
I know Chella.
Yes. Recently I shifted out, sir. So I cannot use
tell us about.
Yes, sir. So I'm presenting a case series of 5 case scenarios. So 2 are like post-traumatic endophthalmitis, and 1 is endogenous and 2 are early post-operative endophthalmitis. So first case is a 38-year-old male who presented with complaints of pain and redness following alleged history of injury with the nail to the left eye, and his vision dropped to contact 1/4 meter, and he was presented to anterior segment OPD. So there he was diagnosed with open globe injury and X-ray orbits were normal, and by the cornea specialist he was posted for iris abscission with the AC wash and corneal tear repair, and prophylactically they have given the intravitreal antibiotics ceftazidime and vancomycin. And then after 4 days he developed endophthalmitis, and patient was referred to the retina OPD. So this was the scenario. So it was nicely sutured, and he has cataract also. And now the B scan is showing the low reflective multiple echoes. So, and then now I just want to wait for a few more days because the questions about the wound integrity. So as a backup with the cornea surgeon, I did pars plana lensectomy along with the vitrectomy, and how much ever the base dissection was possible has been done. Along with the surgical PI and fluid exchange, silicone oil was injected, and finally colistin and vancomycin were injected. So this was the preoperative picture, and with the silicone oil incentive, right side, this one is the picture, clinical picture. So there is no evidence of any retinal necrosis or any retinal vasculitis and any peripheral necrotic lesions. So
very nice picture, very well managed in fact. The
and
only thing is 16 days delay.
Yes, sir. Delay is
you
that.
You are talking of early onset.
Sir, thing is that patient doesn't have this Aarogyasri, that free government card, and he took.
But in any case, result is very good.
Yes,
excellent.
So
the only thing I would add is that you have rightly chosen colistin rather than depending on ceftazidime.
Sir.
Because ceftazidime today, if you are suspecting post-traumatic,
yes, sir,
gram-negative is more commoner, or fungi is more commoner in this.
Yes.
In fact, I would have gone and injected colistin, vanco, and
Vori also.
Yeah.
Okay.
Because post-traumatic, you see, in this country you can't depend on reports too much.
Yes, sir.
It's a clinical suspicion which works. So whenever you have a soil injury means
anything in contact with the soil
segment is not very good, or history of vegetable matter, trauma, that's okay.
Yeah.
But even in such patients, you have done very well. But I'm saying
voriconazole also would have been.
Can be.
Yes, sir. But
okay, go on to next case here, because we want to have every.
And then actually he was doing good, but again after a month he developed recurrent retinal detachment. So then I again reposted it, and this time I have placed the belt buckle also, and then removed the silicone.
This happened with silicone oil inside.
Pardon, sir?
With
the silicone oil,
inside.
After 3 weeks he developed RD again. So now I have placed the buckle, I have removed the silicone oil, and then again how much of the repeat base shaving was done, and then diathermy, PFCL was used for settling the RD, and then re-SY was done, sir. So again after 3 months I have removed the oil. Now the best corrected visual acuity was 2.5 meters, aphakia was there, and yet SFIL has to be planned in the second sitting. And coming on to the second case scenario.
So you can't plan SFIL with finger counting 2 meter vision. You see, SFIL I would definitely do it, but vision has to be at least 624. Na? What are you going to gain by finger counting 2 meter? You can't, if the BCVA is FC 2 meter, he does not gain unless he is a one-eyed patient.
The
No.
reason for the vision to be so less? Because in your
But
first
actually, he
image,
has
the
bit
disc
of
was very
macular.
good.
Pardon me.
In the first image, I think the disc was very good.
Very nice.
Yeah.
So what happened
Yeah.
in the second thing?
So even the retina was settled.
Yeah, so,
So
this is not
be-
looking bad actually.
Yeah,
What
he
is
has.
the what is
pardon
the
me.
vision at this point?
Here, sir. So here also, because of the edema, I have injected IVTS, sir, to decrease the cystoid macular edema. Even though patient is on topical NSAIDs, so the edema
But-
is not subsiding.
But had you sent the reports for, I mean, had you sent it for culture or something?
No,
when you
because
did
the first sitting, the
okay.
thing was done by the cornea
Okay,
people.
they didn't send.
So that's why.
Chalo, okay.
Yeah.
Let's go on to the next patient.
Yeah. And second case is also post-traumatic. Now the injury happened with the stone to the left eye, and patient was seen at an outside hospital, and he is using natamide eye drops, moxicip, dorzolamide, homotropin, and amoxiclav was being started. And coming onto the cornea, there is a self-sealed perforation paracentrally, and he had multiple intrastromal foreign bodies, and diffuse endothelial dusting along with the hypopine was seen, and there is an intercapsular rupture also with the PSCC. So this was the scene, and B scan showed multiple echoes were there along with the RCS thickening, and now the X-ray has been done and it was turned out to be normal. So endophthalmitis diagnosis was made, and this is the picture, sir. So along with the lensectomy, I have done the vitrectomy, and then silicone oil has been injected along with the antibiotics were given in the same way in this case also, and surgical PI has been done in this case, and this is the OCT along with the silicone oil inside the eye. And after that, patient developed macular puckering within 2 months. So while removing the IL, I have removed the ILM also, and IOL has been placed, and patient is having 660 is the vision now with the near vision of N12.
So when are you putting oil in these cases? Are you making sure that you're inducing a PVD as well?
Yes, all the cases have induced the PVD.
So if you have induced a good PVD and you said ILM also, pucker is not such a common.
Sir, sir, actually, yeah, but this is the only case, sir. And we
In
have
fact,
seen very good
if
results.
you show the
with-
first picture, na, I had my doubt whether this is end off also or not. You show the first picture, first, सबसे पहला.
This one.
Yeah. So this is most likely a cataract developing, or
Cataract is there. Sir.
Yeah.
Cataract is there. So that's the reason I have removed the lensectomy also. Yeah.
ठीक है, okay. तो end of doubt है इसका.
And the third case is acute postoperative endophthalmitis. So patient underwent right eye cataract surgery somewhere else in February, and he had a history of journey after 4 days of the surgery, and he went to a marriage and he mingled with all the people, and he didn't use the medications also. So he developed endophthalmitis, and within he presented later to us after 1 week, almost 10 days. So then we have done the vitreous tab, AC wash, and so I'll show you the case, sir. So this was the scenario. So immediately we posted the case, and then fibrin membrane was removed along with the IOL explantation also has been done, and vitrectomy has been done, and again the silicone has been injected in this case along with the intravitreal antibiotics. So
This is very nice.
left picture is the silicone oil filled globe, and the right one is after removing the silicone oil removal along with the SFL was done in the same sitting, sir.
This must be 6966.
6'9", I think,
Very-
6'9".
Chal, very nice.
But
Next.
he has lamellar hole is there in this
That's
case.
okay.
Yeah. Okay.
Next
So yeah, 624 is the thing. And fourth case is also acute post-op endophthalmitis. He developed 4 days after cataract surgery. He presented with sudden painful blurring of vision. So this case was done at our another branch of our institute. So patient was referred from there, and so even in this case the same has been done along with the vitreous tab, AC wash, and antibiotics have been given in this case. And so this is the picture where the surgical PI has been done, and the fundus picture is seen. This is the OCT with the silicone oil in situ, and This is the
My
post.
only question is, you always do vitrectomy as soon as patient comes. You don't depend on antibiotics at all.
Sir, that's what I'm. Basically, whenever I'm able to see, not able to see the first order vessels and disc, and if I have a clear cornea, so then we are actually proceeding directly for the surgical. And if you are able to see the second order vessels with mild grade of vitritis, then we are actually giving antibiotic injection and waiting for it to subside. So we actually has a case series of more than 50 cases. Sir. So we'll be presenting maybe in the next.
Any comment? Please feel free. Anybody? Bolo, kuch bhi. Anybody?
Sir, I would have some questions. Like PVD induction in end-off cases, isn't the retina too necrotic or fragile? Chances of retinal breaks. So in all cases, you have induced PVD. My guide would just say do core vitrectomy, put antibiotics, and come back.
You see, I think
No,
Gagan
PVD
had asked
induction
this
is the
question
basic in any
before
end.
I agree with. You see, before you inject oil, you see, oil is not a thing to be used very lightly in endophthalmitis. You have to have PVD done. You have to remove the entire vitreous and shaving also. Then only oil. Otherwise, oil is not a very good agent for this. So PVD has to be there, and we trust that he is saying that PVD kiya.
So
PVD
as a
index-
beginner, should we attempt to do PVD?
Yeah. That's not an issue. It all depends. You see, my threshold of going inside is not very low actually. If I can see even whatever retinal vessels, I still depend on intraocular antibiotics as the mainstay of treatment, because believe me, most of the patients do respond. Surgically, I go inside if it's a very severe end-off, not as a what you are describing as a mild or to moderate endophthalmitis. In those cases, results in any case will be good. There is no doubt about that. But believe me, intraocular antibiotics results also are very good.
Yeah.
Results also are very good. So I agree that you see, going inside in all the patients doing vitrectomy, creditable, ठीक है, अच्छा काम है. But every patient may not require vitrectomy.
And sir, if there is a subretinal abscess, then is there anything extra that we can do?
Subhyaloid abscess we have seen quite a bit. That is the reason, you see, PVD induction in a patient of severe endophthalmitis is not an issue at all.
Okay.
Don't worry if that retina is necrotic, friable, inflamed, it will tear off.
Yes.
Generally it does not. It does not. But only thing is, I agree, you have to be very gradual in your induction. Like in macular hole, we do very aggressive,
Yes.
200, 300, 400 way pull. Here you have to be very gradual in this thing. But you know, threshold should be slightly higher, slightly higher. You see, you are lucky to have everything very good. Plus credit मिल गया बिना बात पे surgery का ना. It's not
Pardon me, sir.
whatever could have been achieved by antibiotic, you are achieving by silicone oil, iridectomy, सब कुछ कर दिया.
See, I think
So it's not that I have done in every case. So I'm just presenting few
Only for the
cases out of
presentation.
maybe 50, 60.
I think
Yeah.
for the presentation you
It's
should.
okay, it's okay.
Yeah. But
So,
the
but
thing is that
yeah,
whenever the patient gives a free hand for us,
Yes.
No.
No. You see,
Silicone.
honestly speaking, the kind of end-off he's describing, that second order vessels, blood visible, I would not. My indication of oil injection, I think we can ask Barar, Ankuran, is a very severe end-off. Very severe means PLPR plus minus and exudates right till the ora serrata. You can't have a view at all. And the load of infection is so high, one-eyed patient, silicone oil definitely
See,
helps.
as far as silicone oil is concerned, there is always a debate whether it is bacteriostatic or not. So it is not. That is not the reason. I think, as Sir pointed out, I think if you have a good view and if you've done a complete vitrectomy and you're sure about your base, there is no need for oil. But then if you don't have a very good view and you have a very bad case and you're not very sure about your periphery, then I think oil is indicated. But it is not
What is
related
your
to the
name?
infection. Yeah.
कहाँ से? गुवाहाटी. अच्छा. हर्षा भट्टाचार्य जी. So no, I agree with you. Every patient does not require
Oil,
vitrectomy. Every patient does not require oil. That's pakka. And I think I agree with Gagan. Unless it's very severe, very bad, then go for oil.
Go oil, otherwise.
Yes. One last, we'll go on. Shout.
As you discussed, like primary aim of going in the antiviral antibiotics, I also find one advantage that the antibiotics stay in the eye for longer time if there is a non-vitrectomized eye as compared to a
Only thing
vitrectomized
is you have to be lucky. Patient has to be lucky.
Yeah, both of them.
Organism should be sensitive. Then it will respond. And if
most
not,
of the times we are lucky enough to.
Chal. Teja, any other case?
undergo delayed
Another
vitrectomy.
case.
I think we have a lot of learning here.
So another fifth case is there. This is a case of endogenous endophthalmitis. Patient presented with sudden onset of pain, redness and photophobia. So this case has a lot of mutton fat capes along with the cells and flare, and fibrin membrane is also seen. So then we were thinking of, is it pan uveitis or endogenous and then we did all the inflammatory panel of investigations, where the MAN2 turned out to be positive along with toxo IgG also. HRCT turned out to be within normal limits.
This has no relevance at all.
Yeah.
MON2 16, toxo
Sir.
IgG, no relevance.
No relevance. I am just present, sir. So general physician evaluated the patient and started on tab levofloxacin for about a week. So this was the B scan picture of this case, and so now we just
Don't tell me again you have injected oil.
Sir, I have, sir, because luckily in this
You
case
see,
we have done the vitreous tab.
This was a
which
very
turned out
mild
to
kind
be-
of end off. Very
Yeah.
mild kind of end off.
Sir, I would have presented the video, so yeah.
So this would have done even just with the intravitreals, just with the intravitreals.
So in any case, all of us
Yeah.
have learning, because the whole purpose of all this scientific derivation is to learn from each other. But I, for one, may not have injected oil. I would have treated only with antibiotics. And endogenous, we want blood culture report. We want
Sir, in this case, Stenotrophomonas maltophilia has come out to be positive in this case. Luckily, out of 55 cases, we just got 2 or 3 cases with positive thing. And again,
So in any
battery-
case, Teja, we have learned from you that you have a very low threshold of vitrectomy and oil.
Yeah, I had one more
Let's
point
have
to add on.
Ankur, you can come this
So-
side. नहीं जब तक आप बोलते till the time Ankur says. But in any case, all the photographs have been very, very good, very, very good.
Fine.
But have trust on antibiotic also, and do not rush for oil every time.
Sure.
It's
Yeah.
okay.
So because out of 60 cases, I have done only in this thing 5 cases. So that's the reason I have
You see,
said. Not for all
we
cases.
were the first people. 30 years back, we described oil. At that time, we were actually ridiculed at that time. हर एक में oil डाल रहे हैं. But we had all very bad endophthalmitis. Very bad means PL plus minus.
Sir, after injecting oil, sir?
No.
Ah.
Oi, after injecting oil.
Okay, use of oil. Fine. Okay.
Don't. We are not so bad surgeons, but
No, I'm just
after injecting oil, our mean visual acuity of that time was 660. But oil saved us in a lot of these eyes. Chal, thanks a lot,
Okay, sir.
Teja.
Thank you, sir.
Yeah.
Excellent job. Keep